Keep your mic on. Hello, everyone. Welcome to Room Now's review of ankylosing spondylitis, the spondyloarthritis from Eular 2025 in Barcelona. I'm here with the faculty that covered SPA and all its great presentations and posters. Last week, we were all in Barcelona. We're all home, rested, and we've had time to reconsider what we heard, and we're going to present that to you today, so our favorites from Eular 2025. I'm Jack Cush in Dallas. I'm joined by Adela.
Hi, I'm Adela Castro from University of Tennessee, Memphis.
Yus.
Hello, my name is Dr. Yusof. I'm a rheumatologist from Leeds, United Kingdom.
Professor Nash.
Hi, Peter Nash, Professor of Rheumatology, Griffith University, beautiful downtown Brisbane in Australia.
And Antoni.
Hello, I'm Antoni Chen. I'm a consultant rheumatologist from United Kingdom.
So we are globally represented. The rules here, we're going to each present two of our favorite abstracts and discuss its impact and import for you. Let's start with Dr. Castro.
Alrighty, so the first abstract is the OP0307, and this abstract was a South Korean study that aimed to improve the clinical diagnosis of axial spondyloarthritis. And in this study, they used a deep learning model that integrated structural and inflammatory changes on sacrum MRI. They took data from 291 patients with chronic back pain who underwent MRI, and these were analyzed. In general, 163 patients were classified as having axSpA with a sensitivity of over 85% and specificity of also over 80%. So, and this was also with an accuracy of 85%. So this was very interesting to see. Something that also caught the attention because it was a little bit in the session, it also caused a little bit of kind of like emotions was, that there was a small amount of patients that did not meet MRI criteria, but were actually classified with axial spondyloarthritis.
So what was the gold standard when they were comparing the AI results? Was it the locally read or was it centrally read images?
So in general, what they were comparing, they were kind of like doing the combination of the model with the structural images. So they kind of like the radiology with the bone marrow edema, with the STIR and T1 weighted images, with the deep learning model analyzing it. They were not kind of like in depth as far as like, what was the gold standard comparing it, but what they were saying is that's what it caused a lot of controversy over there, was that, they felt that the combination of the deep learning model with the previous imaging was very kind of like the useful of the trial.
Antoni, what do you think of this kind of report?
I think that it's useful. Increasingly, we are seeing more of these type of AI type models, but I think it's also important for a few things. One is that there's a human in the loop in the model, so that there is some verification at the end. I think these things at the moment are stratifying whether this is high risk or low risk of a particular condition, and rather than being definitive.
So Peter, when one of the problems with imaging being read, there's a big difference between locally read and centrally read. Do you think that AI being applied can supplant the centrally read image reading?
I think it's very important, Jack, because if you're misdiagnosed, as we all know can happen with MRI by itself, especially read by a radiologist who's not specifically interested in musculoskeletal medicine, people carry a label and they just cycle endlessly through biologics. So I think any attempt to increase the specificity and the is very important, and these kinds of things will only help.
Yus, I'm sure you have a comment on this because you're at Leeds, and Leeds is like a world leader in imaging and advanced imaging. What's your impression of this, and what are you hearing about what's going on at Leeds?
Yeah, so I think pertaining to the abstract as well, I think they mentioned the area under the curve. I think it's a little bit 0.9 after using the AI. I think that's pretty high compared to, so the standard rating. But certainly, I think, more validation need to be done. But also sometimes we also, can't treat things like a machine, isn't it? So I think it has to be correlated with patient symptoms. That's where the clinician input also really matters, in this way. But certainly in, around the UK as well, there's a move now where, not just for expa, but also others, diseases are using more AI generated reporting. So I think that it is coming to your door, but certainly we just have to be careful on that as well. Yeah.
Adela, you get final comment on this.
So I agree with all of what you said. I think we're going to see more of these. I think this is helpful. And I think it combines the clinical with the findings on imaging. So I think that with the more universal that it stays, the more validation that it gets, it's going to be it's more going to be applicable for our patients.
Excellent. Let's move on to Dr. Yusof.
Yeah, okay. So the abstract that I want to present, the number is OP0099. So essentially, we know that patient with ankylosing spondylitis can have various comorbidities, and one of them is psychiatric comorbidities such as depression and anxieties. What we don't really know, and a limited study about it, is what happened in terms of the incidence of these following a diagnosis of AxSpA. So basically, this is a study that was done using combination of Denmark and Sweden. So it is an inception cohort when it was first patient diagnosed, and then they followed up. So it's very large in the populations. I think over 9,700 in the total in combination. And also they will also then compare it to a matched population, like general population. So basically ratio 10 general population to 1 patient. And this is matched with age and sex. So in terms of the incident itself, so when they record about the anxiety and depression, so using the ICD code, and so also they try to compare the incidence of a patient who receive outpatient and inpatient psychiatric care for anxiety and depression, or patient just inpatient psychiatric care, and also whether there's any suicide. So what they found out of these three variables that they were looking for, so patient who's been diagnosed with AxSpA have increased incidence of outpatient or inpatient care for anxiety and depression. So the hazard ratio was around 1.34. There was no difference for patient who required inpatient care or suicide between general population. So what really what this study showed that we are very good in managing patient inflammatory symptoms, and also we are getting better at improving patient's quality of life and symptom control. But also we need to also emphasize on comorbidities, particularly people with AxSpA, and depression, anxiety is one of them. So I think we really need to look into our services so that we can have this provision of access of therapy of this psychological therapy potentially. And also as a clinician in clinic, we also need to know how to signpost if the patient have some depression problems, to signpost to the appropriate services. Yeah.
Did they link this finding at all to spondylitis stage or disease activity?
No, they didn't search for that. No.
Okay. Peter, what do you think?
I think it's important, Jack, because this whole complex to manage story is very much driven by anxiety, depression, as well as chronic widespread pain. Some of the drugs have been accused of causing aggravation of depression, but I think rheumatologists are very poor at managing this whole area of our care. I say the word depression and the patient says, "You think there's pains in my head, doctor?" I say the word psychiatrist, they say the same. So I just think we manage it poorly, and it's an important part of the patient profile.
Yeah, Antoni, how do you handle these issues?
Yeah, I think these are important topics, and we increasingly are measuring PROs in our patients routinely because even if we find that the disease activity score improves, the PROs don't improve at the same rate. And if you go back to some of the original papers, if you look, scores like HAC or BASFI, the functional index, actually poor predictors of future biologic response. And now we're starting to understand that there is this non-inflammatory pain that is also working in conjunction with some of the treatments that we are giving our patients.
Yeah, Adela, what do you think this data does, or finding depression, anxiety does to clinical responses?
We already know that, it has been associated in patients with difficult to treat axSpA as well. So I think this is important to screen. We do have the rapid questionnaire to screen for depression. And then we definitely have to take action because, that's when we see the patients not responding and cycling different therapies. And the problem that they had initially was depression and anxiety.
Yeah. So you don't need to do a Beck depression inventory to find this. You can do a simple 9-question PHQ-9, but a 2-question PHQ-2, and add that to your documentation. I have 1 question on my survey form that all my patients see, and it's bold. Do you have depression and anxiety? And then after that, it's up to you to address it in a manner that you think the patient is going to be receptive to. And I think that Peter's point is, how do you discuss these sensitive issues and bring it up when they may be resistant to discussing it or bringing it up? So, but I think that it starts with us in identifying the problem. Use any last comments on this?
I think I do agree with all the discussions that we talk about. I think we just need to be a bit more better now, to screen, for these comorbidities. Yeah. Mm-hmm.
Okay, let's move on to Dr. Nash and what he enjoyed.
Well, this is a little bit obscure, but I think it's still pretty exciting, Jack. They found B27 patients with AS and those without. In their blood, the synovial fluid, the synovium, they had these particular CD8 T cells that express this motif called TRBV9+. And about 4% of your T cells do that. And in 2019, they found a patient who was positive for this. They found this in their peripheral blood. So they gave this guy monoclonal antibody to TRBV9, and he went into remission. He flared 9 months later. They gave it to him again, and he went into remission again. And he's been in remission for 4 years. And it turns out that B27 presents self and bacterial antigens to T cells, and some of them become autoreactive T cells. So how could they make this monoclonal last longer? They used the BiTE therapy, and they took a bispecific antibody that made a bispecific CD3 plus TRBV9 is expressed, makes a T cell die. They used CRISPR technology to really specifically target that one motif on the T cell. So it only kills the 4% that express this motif, leaves all the 96% alone. So it's not immunosuppressing. They showed it's potent and specific. Now they've got to get out into human trials. But I think it's an exciting avenue because this particular motif is expressed in the whole axSpA spectrum, AS, PSA, uveitis. It's even expressed in Crohn's, in celiac disease, and a series of other autoimmune diseases, and might represent a nice, completely alternate way of treating these patients.
So this was a proof of concept, with a patient experience, and then now the idea of rolling it out to clinical trials, correct?
Yeah, exactly. So this particular paper just talked about the manufacture of the BiTE,
Right.
and how potent and specific it is with no clinical details. So they really made something that might be more profound in getting rid of the T cells that are autoreactive alone and last much, much longer.
And what's the expectation on B27 positive patients with AS? How many will be TRBV9 positive? Potential
A high
candidates?
percentage of
Really?
percentage of them will.
Oh, this is
And it's quite specific, the immune suppression. It's not a broad knocking out all those T cells. It only knocks out the T cells that express and react to this motif.
Antoni, do you think that this is going to do for spondylitis what CD19 CAR T cells did for lupus?
I think it's going in that direction. Whether this is the only cell clone that maybe we might discover more, but at least it's a start. And I think I did attend this this poster as well, and I was quite interesting to see how much it developed since it first was discovered. This is going to be a first of its kind, really, for this SPAO, because we haven't had this type of more specific targeted therapies.
This is, what do you think, Yus?
Yeah, so I think this is it certainly opened my eyes as well, actually. You thought, all these bites and CAR T cell will be more for like B cell driven disease and not so much in AxSpA, but you do found this some molecule that express it. So it'd be interesting, like, you do have the proof of concept from animal studies, but we just need to see, like, what happened translate to human studies. I think if, it has a role that potentially maybe we can, consider this in patients who are, refractory, treatment refractory, which we are going to be discussing later on in, in our panel. Maybe there is some subgroup of small patient that can benefit from this potentially.
And Dr. Castro, what do you think?
I agree with you at this point. I really want to see the studies, actually, because a lot of times we see a lot of things kind of like in basic science, but when we translate, it doesn't translate equally. But if it actually works in the studies in human, I think it will be a very good, way to do more precision medicine in this type of patients.
Peter, I'm glad you presented this because in our friends who we run around with at the meetings, the ones who are those spondylitis mavens, which you guys are all part of, they're really excited about this TRBV9. And to target it makes a lot of sense.
Yeah, I think it's got legs in other diseases as well.
Yeah, excellent. All right, let's move on to Dr. Chan.
So I've got a OP0098. This is the concept of difficult to manage AxSpA, and this is a study from the Rabbit Register, the German register. They had over 1,800 patients. 48% were biologic naive, and then they found in this group that 8.5% of them were classified as difficult to manage based on the ASUS classification, which is 2 or more biologic DMARDs and the physician and the patient feeling that their disease remains active. But in that group, there was 2.5%, which they class as treatment resistant, and that is difficult to manage, plus one of a few things: high CRP, high ASDAS, positive MRI, and sacroiliitis. So there were many other similar studies at this conference which kind of dealt with this concept of a D2M and treatment resistant. So I thought this is going to be a start of this classification and how we would think of the different treatments for these patients.
So we heard about D2M and C2M yesterday in talking with the spondylitis faculty. They seem to be excited by this. Peter, what do you think?
Well, I think it's only going to be relevant, Jack, if we can have predictors and then change the way we start our treatment and do some strategy trials. I think the key difference is one group has to have objective evidence of inflammation, either on imaging or on acute phase reactants, etc., high disease activity scores. And the other, we treat differently: duloxetine, physical therapies, injection surgery, and not cycle endlessly through expensive biologics. So if you can hive off that small group, we should start in combination. We should then bring down to maintenance. We've got to do all those strategy trials, I think.
Adela, you follow this literature.
Yeah.
You saw what happened in PSA, and now here. There's a little difference between GRAPPA and the Eular. People who are looking at this, are you pretty clear on where this is going? Or are you confused by the nomenclature and nosology differences?
No, I'm not confused, but something that I remember I like about from Elena Mars Ortega, that she said that this is not a different disease. This is a state of the disease that can vary over time. So this is something that is important to recognize, and it's important to kind of like address and find not only the biologic factors, but also the comorbidities, the inflammatory factors, the reaction, the medications that we're using. So it's going to be important to kind of like take more than one consideration, not just the disease activity itself.
Do you think this will help clarify treatment choices in the future?
Yeah, so potentially, I think the implication is what, as per, Dr. Nash mentioned earlier, for example, like people with D2M, potentially we may need to start, combo therapy. So it's not just cycling through the immunosuppressive therapy, there are other aspects, like comorbidities or, aspect with fatigue, fibromyalgia that we need to tackle together. And certainly just looking at this report from this registry, the rates of the D2M is quite similar to other diseases as well. So I think other disease in rheumatoid arthritis and psoriatic arthritis, the reported prevalence around 5 to 20, and they found around 8.5%. So I think it fits, it matches. The only thing I just want to slightly comment is I just heard a few patient were talking during the conference actually. I think because when they see the topic and title, we discuss about difficult to treat. So I think, we understand what it means, but I think from patient perspective, they really sometimes take it to heart. They say, well, are we being difficult? This is what I mean, like, and, sometimes they went to like children in the conference and like, patient high symptom burden, like they felt like they were burdening us. So I think maybe some languages thinking that, we need to
Yeah,
look into as
it's
well,
changed to
when we talk.
treatment
Yeah,
refractory now.
Yeah. All right. So that was presented by Dr. Chan, correct?
Yeah.
Okay. So
Yeah.
now we're going to begin our second round with Dr. Castro. These are shorter. Go.
So the next one is the abstract OP0310, and it was also very interesting. This actually evaluated structural lesions on the spine of patients with early AxSpA compared to patients with non-AxSpA and chronic back pain, and this used the data from the SPACE cohort. They combined the findings at baseline on conventional radiography and MRI, and then compare it with the findings 2 years later. And they did not see any difference between the AxSpA and the non-AxSpA in terms of conventional radiology. However, on MRI, they did find that patients that had early AxSpA had more fat lesions, and these fat lesions could be a potential markers of disease activity in patients with AxSpA because they did not see this on patients with non-AxSpA with chronic back pain.
Question is, how significant are fatty lesions or even bone marrow edema when the most specific are erosions, right? I don't know who's our XBot MRI expert here that wants to comment.
I'm not sure, but I think that the real problem is you need a clinician to interpret this stuff, or you make tremendous over diagnosis. And who does X-rays anymore other than when you have to for the government? MRI is the kind of the key diagnostic criterion now, with clinical features and a CRP. So we've practically stopped X-raying these patients.
Really, Antoni?
Yeah, we we only use X-rays for classification because there was a time when we had to differentiate between non-radiographic and radiographic for access to treatment, but that's all changing. So we are using less of X-rays. I just wanted to check with Adela, did they look into the group with OCI, osteitis condensans, in the non-radiographic, in the non-XPAR group, because that group often can cause a lot of misdiagnosis, and follow-up of that group is probably more important.
No, they didn't. They just had like the cohort from the SPA patients from the SPACE cohort, and they just compared it to the non-AxSpA with chronic back pain who went both imaging, but they didn't say, what other conditions the non-AxSpA patients with chronic back pain had.
Okay, revealing. Let's go on to use.
Yep, so the quick round one, the abstract OP0097. So the in terms of the treatment to target in AxSpA, so the ASDAI Society has defined criteria, to aim target of inactive disease defined by ASDAS less than 1.3, or at least low disease activity, which is defined by 2.1 or below. So although these patients can meet the target, some people still have some symptoms, so not perfectly, completely in remission, as we say. So as we know that when we do have targets, one of the important objective is trying to prevent from flare and also improve long-term outcomes. So what this study did was, it's actually a Dutch study, so using a SPA-NET cohort. So what they found is they're trying to evaluate whether these people who met the criteria of at least low disease activity, whether do they have any flare over the next 12 months, and if there is, what other things could be predictive. So what they found, over the 12 months, they found a rate of flare of 26% flare. So when they look into variables, with variables predicting the flare, so they did separate into two variables. One that evaluated, one is the objective residual. So basically, there's some component if you have, for example, like one swollen joint count, or if you have a little bit of psoriasis, or raised inflammatory markers. So those are the objective one. But also there were some residual, like patient experience residuals. So these, for example, if you have a little bit higher fatigue score, back pain, and also BuzzFeed. So what they found, in the multivariable analysis, so patients who have patient experience residual, despite being on low disease activity, were associated with risk of flare for about, a ratio of 3.4, and also time to flare as well. So looking at a bit more detail in terms of these patient symptoms, so the one that predictive is more like fatigue and BuzzFeed, not the back pain. So I think what really this study shows is, although patient are categorized, meeting our target, we still have to focus on other symptoms, such as the fatigue management, and also other things like limitation in physical function. May need some input from occupational therapists and so forth, because all this holistic approach will then hopefully prevent from risk of flare over the next 12 months.
So I don't think it's surprising that people who are in low disease activity state, more so than remission, are at higher risk for a little flare, or more flares going forward. But what this study showed was that the ones with objective inflammation were half the flares, and the other ones with the subjective things were the other half. We're getting back into C2M and refractory disease, non-inflammatory disease versus inflammatory disease. Does Dr. Chan, do you view it differently than I?
No, I think it's the same concept. This is why these definitions are going to help us in terms of choosing our treatments. And also what we are seeing is that across all these studies, we are finding common factors, being female, having peripheral arthritis, obesity, depression. These are the factors that are going to have patients still complaining that they're not well, despite us achieving a low disease activity or remission states.
These are all important points as relates to whether you're going to, as Dr. Nash says, write a prescription for therapy or duloxetine, or for a new, $60,000 biologic. Any final comments?
I'm not even sure half of them are flares, Jack. If you get a bit of extra back pain and a bit more fatigue, that sounds like me after a game of golf. So I just think without objective evidence, either on imaging or in bloods, I think a lot of this can be overdiagnosed.
Yeah. Okay. Peter, what's your second favorite?
This is a very quick one. It's really this question of axial PSA is very different to AS with a rash. And I think it's a nonsense argument, but I'll try and give you some background. This is POS 0297. They looked at the Eurospar, 5 countries data, 580 patients, 373 PSA, 208, what they call AXPAR plus psoriasis. And they looked at imaging to see MRI and radiographic sacroiliac joint involvement in these patients to see if they could separate them. And lo and behold, 1 in 3 of them had evidence on imaging of AXPAR, and about the same number met the New York criteria, could have gone into a trial for AXPAR. If you're younger, you're more likely to have inflammation erosions. If you're older, you're more likely to have ankylosis. And guess what? If you've got PSA, you're more likely to have dactylitis and nail disease. And if you're an AXPAR, you're more likely to have uveitis, enthesitis, inflammatory back pain, and a positive B27. So I simply think this is 2 ends of the same disease, 2 different phenotypes, Nash type 1 and Nash type 2. And all it means is that the genes you're dealt decides what kind of expression you have. If you're B27 positive, you'll have axial involvement. If you've got a different set of genes, you'll end up with peripheral arthritis, nail involvement, and a rash. And I think that they are otherwise we're going to have axial dactylitis and axial enthesitis and axial uveitis. I think this argument is a false argument. They're two ends of the same spectrum.
Did I hear you right calling this Nash type 1 and Nash type 2? You're
I was
just
going to call it Cush. I was going to call it Cush type 1 and Cush type 2.
I'm thinking the Nash is going to stick. But I think that these are sage comments and good ways to consider this. Of course, the big issue is why does IL-23 inhibition not work in spondylitis and will it work in PSA spondylitis? I mean, those issues are being studied in a clinical trial, are they not? So
They certainly are. Yeah.
any other comments on this?
Sorry,
If not,
I missed, just now, Peter, did they compare about prevalence of bowel symptoms in between the two?
They looked at. I'm not sure exactly if they labeled it or not, but I think they would have in fact looked for that as well.
Yeah.
But I think just think of leprosy, the same antigen. One end you got tuberculoid, the other end you got lepromatous. They're the same disease.
Mm-hmm. But let's
So
be
you're
clear,
yeah.
spondylitis has nothing to do with leprosy. Let's just be, for the lawyers that may be listening to this. Okay.
Yeah, so I think this is the whole discussion of whether you're a lumper or splitter. And I think the discussion tonight is probably we're lumping everything together as one disease.
Very good. All right, Dr. Chan, give us your final presentation.
So the my final one was the Axia app. This is the late breaking abstract 002. This is the Axia app presented to 200 patients. They were randomized in an RCT 1-to-1 between doing the app or doing standard of care, 12-week RCT, and the app won with a reduction in best diet, best fee, quality of life, ASAS 2040 better in the app group compared to the standard of care. The app was demonstrated. It has interventions such as exercise, education, and some gamification as well. So kind of keeping people interested in this. So I thought it was interesting. The first digital therapeutic that I've seen with a positive outcome. Why would we need it? Well, I think there are issues with shortage of workforce and ability to see people in clinic. This could be an option in that situation.
So for clarity, it's AXIA. This is a phone-based app. It teaches people a number of different algorithms on exercise, and they either were engaged with that, half the group, and the other group didn't have an app. So they had nothing. The first person to ask a question at this session was Dr. Castro. Adela, why don't you restate your question and your concern about, again, very obvious differences. The treatment group had clinical trial-like results as far as ASAS 40, ASAS 20, BASDI change, etc. And very little change in placebo or control group, but big changes in the Axia group. Go ahead, Adela, what was your comment?
Yeah, so my question, because of these differences in the results, because even the placebo effect was very minimal. So my question was if there was any specific bias, particularly the Hawthorne effect, the patients that are being evaluated, of course, do better because they know they're being evaluated. But then that was something that was a question because, the other patients were on nothing. So that's something that they were like, it's possible, but again, they kind of like circled around. But it is a valid bias on this type of interventions when we don't have any other competitors.
It's
Jack, was this
amazing.
Austrian or German? German or Austrian? I think it's very cultural
German.
who will pay attention and do as they're told.
It was German, right?
Yeah.
It was
is,
German.
Yeah.
Yes.
I'd like them to try it in Australia. I'll tell you there'll be a difference.
Well, there was a few. First off, I see an app working really well in a non-pharmacological. I'm like so excited about this, so into this. But if you follow the details, the results are kind of believable. But if you're a skeptic, maybe not. And then if you looked at the details, 74% of the intervention group were female. 52% of the placebo group were female. I thought ankylosing spondylitis was a male disorder. And then
You asked that question.
yeah, and he paid no attention to me telling me that spondylitis is a 1-to-1 disease. And I said, yeah, if you want to be politically correct and you got a microscope out on everyone, sure, but not in the real world. And then the other problem was that And I like his point was that women are really good at filling out apps. Women are really good at following instructions. Women are really good at doing exercise. And that may be underlying some of their results. But if you look at the profiling, 32%, 33% of both groups were active in athletics. Peter, how many of your spondylitis patients are playing cricket and rugby on the weekends?
Man, they're too busy working, trying to earn a crust to be doing anything like that.
So
Half of them, yeah.
I think it's exciting. What's your comment on this?
Yeah, so yeah, I've heard both of your questions on the day. I think he had quite a lot of grilling in the Q&A session. I think also just to think about in terms of dissemination and scalability and also languages. I think they said they've started it doing rolling out in Austria, but obviously there's quite a lot of things, you need to translate in English and other languages as well to be wider applicability. So I think that's probably a different challenge as well after this. Yeah.
Peter, Austria compared to Germany, isn't Austria Germany with better beer?
I'll be careful now, Jack. You've got to be politically
I'll be
correct.
getting calls. Okay. Any closing comments on this exciting abstract?
I did find it very exciting because it's a non-pharmacologic therapy. Whether the results that they presented, I found them that they're very too great to believe. I think ideally on a control study with the same app, for everybody would be ideal, especially because, they were, even all the measures were even better than the biologic therapies, which you see still really high placebo responses as well. So I was like, I need more data on these.
They need a
I
sham
think we
expert
need
to compare it to.
And-
Anthony, you
yeah,
get
we
final
need
comment.
and
yeah
different
we need
cultures
longer
too.
Yeah,
yeah
maybe.
we need longer term data for this to see whether this is sustainable. But if it is, I think this comes back to a whole discussion about complex to manage. And all these kind of patients with a lot of these other non-inflammatory, could be that we could send them this app.
Okay, I want to thank our spondylitis mavens for their hard work last week at the meeting and covering spondyloarthropathies and educating our audience with all the good stuff from Eular 2025 in Barcelona. That's it for this review. There's plenty of more content that you can consume either by video or by podcast. Thanks to our faculty. Good night.
Bye,
Thanks,
everyone.
Jack.